Hi, I'm Greg Nowakowski. I'm a lymphoma specialist at Mayo Clinic, Rochester.
Oh, hi, I'm Christian Grommes. I'm a neuro-oncologist with focus on primary CNS lymphomas here at Memorial Sloan Kettering Cancer Center.
Hello, I'm Katherine Peters. I'm a neuro-oncologist at the Preston Tisch Brain Tumor Center at Duke in Durham, North Carolina.
Hi, I'm Avyakta Kallam. I'm a lymphoma specialist at City of Hope, Duarte, California.
Let me just start from asking in general, what are the current therapeutic pathways in patients with CNS lymphoma? It is a difficult to treat diagnosis, as we know. So how do we currently approach those patients? Maybe I'll start with Christian.
Yeah. Well, we have a long history of treating primary CNS lymphomas here, and obviously with Dr. DeAngelis establishing RMVP, and people seek us out because they want to be aggressively treated. So we usually do methotrexate-based chemotherapy in the first line. Usually not single agent. We like to combine agents, RMVP, RMT, or temozolomide. Also, we have trials ongoing with BTK inhibitors integrated in the RMVP regimen. Again, I feel this is a curable disease. I want to be very aggressive. This is nothing new for the lymphoma world. It's new, not new, but it's different from the neuro-oncology field, where we usually have more like palliative approaches, obviously, with glioblastomas. And that's something that I see commonly when I see patients referred to us that they didn't respond to methotrexate and labeled refractory. They were just undertreated usually, and some of my colleagues are a little timid in combining agents. So I think that is the biggest educational piece for neuro-oncologists out there, to be not timid. Again, novel agents have been introduced with BTK inhibitors, but we are really lagging behind the general direction of the lymphoma field in primary CNS lymphomas.
So, Kathy, we've heard that frequently there is indication to start induction therapy with combination of chemotherapy agents and pretty aggressive. How do you actually select the patients for particular therapy? Because we know that some of them can be quite sick, and unfortunately, CNS lymphoma is a disease of the elderly as well, which increases the difficulty of tolerance of some of those regimens.
Of course, functional status has to come into play because the patients need to tolerate the medication. I think giving them an opportunity to initially respond to the high-dose methotrexate therapy with polychemical, and seeing how they respond, usually they can respond quite robustly, and you can advance therapy after really the first 1 to 2 months of methotrexate. This can even be done in the elderly. Of course, you need to monitor them carefully. You need to make sure that they're appropriately staged at the very beginning, because they can be so neurologically challenged initially. You want to get them started on therapy as soon as possible, but you need to make sure that the patient is properly staged at the very beginning, before commencing on therapy, unless it is a true emergency. So I would, again, first say, give the patient a chance. Don't, just send them to palliative care. I agree with Christian, to give them a chance first 1 to 2 months, and then you can essentially become more aggressive with your therapy. And don't forget that now we're having more clinical trials that are novel in this space. So inclusion into clinical trials is so critical in getting those patients on trial.
So, Avi, Kathy mentioned something very important, the initial workup of those patients and staging. And we know that CNS lymphoma could present as a primary CNS lymphoma versus secondary involvement. Particularly extranodal lymphomas can have a secondary involvement, and it's very important to exclude it. How do you work up those patients in your practice? So if you see patients, let's say, presenting to ER with the seizure or mental status changes with the lesion, and they're then sent for the biopsy, it shows CNS lymphoma, what's your next step in working those up?
Yeah, usually the first thing that we do after a diagnosis of CNS lymphoma is we do a staging PET scan, or CT scans, chest, abdomen, and pelvis, sometimes if we don't have the capability to do a PET scan right away. I feel like that's very important because quite often, like you mentioned, secondary CNS lymphomas can also be something that could present with just CNS involvement initially. So I would say important to do staging scans, if needed, a bone marrow biopsy, depending on what the patient's blood counts are.
What about ocular examination? Christian, do you do it in your practice? Because intraocular lymphoma can also spread to CNS, right?
That's right. So first you have isolated ocular lymphoma in patients with, blurry vision, floaters, and these patients usually have a very long, protracted course because they present, it's a vitritis, could be an inflammation, they get eye drops, steroid eye drops, they get better, and it's up to months and years before they really have a tissue diagnosis, which is usually a vitrectomy. And 20% of patients with isolated primary CNS lymphoma have eye involvement, and it's important to establish that before you start treatment. Well, in the first week or two of treatment, even I would not hold treatment for an eye exam, but the eye exam should be performed because you want to track that the eye is responding. I have experienced multiple patients where the parenchymal brain lesion improved, even the cerebrospinal fluid improved, but the eye was not getting better and the patients had symptoms. And you sometimes have to either follow that up with local treatment, which could be also injections with methotrexate or rituximab, or even radiation, to make sure that this is not a source of a recurrent disease down the road.
So the mainstay therapy is methotrexate, high-dose methotrexate-based chemotherapy, either in combination of rituximab, maybe temozolomide, cytarabine, and other combinations are used commonly as well, particularly in Europe. So a variety of induction treatments. Fortunately, they appear to be having pretty high initial response rate. And then the question is what to do next. So Avi, what do you do next? So the patient is responding to initial regimen, and what's your next step in consolidation?
Yeah, so you're absolutely right about needing consolidation. I feel like CNS lymphomas, the recurrence rate is much higher when you compare to systemic lymphomas. So we usually follow it up with consolidation, which is either a myeloablative strategy or a non-myeloablative strategy. In my clinical practice, we've sort of leaned a little bit more towards a consolidative autologous stem cell transplant. So that's been our go-to approach in a patient that we feel like is fit enough to be able to tolerate a stem cell transplant.